Hi everyone, my name is Sridevi Rajeeve. I'm an attending at Memorial Sloan Kettering Cancer Center in New York, focusing on multiple myeloma and cell therapy.
And then my name is Dr. Rahul Bannerjee. I'm an assistant professor at Fred Hutchinson Cancer Center in Seattle, other side of the country, also specializing in multiple myeloma, CAR-T, and AL amyloidosis. And so we're here at the IMS, the International Myeloma Society meeting live in Rio de Janeiro. A little cloudier than usual today, but it was a great session. A lot of things have happened here. We are going to have a fake debate about MRD, measurable residual disease, and whether it should guide decision making or not. So I'll let you go first.
Absolutely. So, the whole aspect about MRD, which initially used to be called minimal residual disease, but the court field is moving towards it being called, and an effort led here by Dr. Banerjee to be called measurable residual disease, is generating a lot of interest among doctors, patients, caregivers into how MRD can be used as an effective tool to advance therapy. So what exactly is MRD and why do we have so much emphasis on it, right? So MRD is one way of testing how many residual myeloma or any form of disease is there inside the body. It can be tested in many ways, and one of the most reliable ways we test it is by testing a bone marrow sample using a couple of different techniques called next generation flow or next generation sequencing. Now, the difference is that next generation flow has a sensitivity of 10 to the power of minus 5. Next generation sequencing has a power of 10 to the power of minus 6. So the difference is that next generation flow might be a little more accessible to almost all institutions and therefore to more patients. However, next generation sequencing is dependent on having access to the third-party company that does it for us, which is often not accessible to a lot of institutions and therefore, again, not to a lot of people. So I'm going to take the side of why we should be doing MRD assessment, and Dr. Banerjee here is going to be like, okay, MRD is not quite ready for prime time. So the reason that I'm going to argue that MRD is at prime time at this time is because of this year's FDA's ODAC meeting, in which the the Food and Drug Administration with USA had this big meeting with very prominent doctors all over, and we all were discussing whether MRD is ready to be considered as an endpoint in clinical trials. Why is this important? Because the gold standard of whenever we try to bring a drug to patients is that we try to see if there's a survival benefit. The main survival benefit we look for is something called as overall survival. However, for a trial to report out overall survival, patients have to live that long, we need to collect data, and it takes around 8 to 10 years to get that overall survival. So if you imagine you're waiting for 8 to 10 years for one drug to be approved by the FDA, patients may not live that long to get this. So we need to have a surrogate or, something that can emulate the benefit that overall survival is doing by having something called a surrogate marker. So the field had moved towards something called as progression-free survival quite a few years back. Progression-free survival really cut short the timeline of how we can bring a drug to a patient from 10 years to, let's say, 4 to 5 years. Again, is that good enough, especially for diseases like, myeloma and other diseases where patients really relapse very quickly, very suddenly, and there's an urgent need to change therapies every year or perhaps multiple times a year? No, we need to get these drugs to patients much faster. Here enters MRD. Now, MRD is now touted as a surrogate marker for both PFS and overall survival in multiple studies, and a large meta-analysis did prove that MRD negativity, that is the achievement of no detectable disease inside the bone marrow or peripheral blood, can be attributed to a survival advantage in both progression-free survival and overall survival. Clinical trials that use MRD are now able to show a response to therapy, and we have a basis for actually approving drugs in as small a time as 1 year, which I think is going to be very beneficial for patients, especially now we are having patients who are relapsing after multiple diseases. They're waiting for small molecule drugs and other drugs, and if we can get these drugs to them quickly in a matter of like 12 to 18 months, I think that therein lies my argument that we should be considering using.
Agreed. So you can see from me nodding that I actually agree with Dr. Rajeeve entirely in everything that she said. We're supposed to be debating, so I'll just add one layer of nuance here, is that there's a difference between MRD being used in clinical trials as an endpoint for regulatory approval versus for the patient sitting in front of us in clinic. And so I do check MRD pretty routinely as standard of care, meaning for my patients in my own clinic outside of a clinical trial. However, before we start going down the MRD rabbit hole, so to speak, I always have a discussion with my patient first that if you achieve MRD negativity, meaning that, as Dr. Rajeeve said, on a bone marrow biopsy, no sign of the myeloma, one, that doesn't equal cure, and two, it's not a requirement. There are no data to show that forcing someone to achieve MRD negativity has any benefit to the quality or quantity of life, and truly it might actually hurt a patient by trying to push for MRD negativity. Because again, it's not necessarily a measure of it's not just a measure of the treatment, it's also a measure of the disease biology, and everyone with multiple myeloma is different. And I have had patients who are MRD positive for many, many, many years, and Cindy's no exception to this, and I think, how is that possible? MRD doesn't necessarily, if MRD is detected, it doesn't necessarily mean that those cells are cancers, it just means that they're abnormal. They came from the same clone that these cancerous cells came from, and some patients may have what's called an MGUS-like phenotype. You may have heard of MGUS before, monoclonal gammopathy of uncertain or undetermined significance, which is a precursor to myeloma, where the cells are there, they're clonal, meaning they're growing a little more than they should, but they're not yet causing CRAB criteria, not yet causing symptoms, don't yet require treatment. I can't say that if you were to check someone with MGUS, for example, and look at MRD in their bone marrow, obviously they will also be MRD positive, just like with smoldering myeloma, et cetera. I can't say that someone has MGUS after they've had cancer, because MGUS is pre-cancer, but there's an MGUS-like phenotype where some people truly for years after treatment for myeloma may still have some abnormal cells there, but no symptoms. And so I think MRD is very nice as a tool to de-escalate therapy in select scenarios, but not one to escalate therapy, go up on therapy. As you can tell, we agree on 99% of it, but every case is so different. So I would say for those of you watching this, talk with your doctor about it. And certainly I think, if MRD were into blood, things would be a lot easier. There are blood-based techniques that are under investigation. Right now, the only FDA-approved ones are from the bone marrow. And so we have work to be done to improve how accessible MRD is, but also how useful it is. So I would say talk to your doctor about all these nuances. And again, don't rush to, or don't believe that you have to achieve MRD negativity. The goal of cancer treatment is to live as long and as healthy as possible, and we don't quite know how MRD fits into that yet.
And to play my own devil's advocate, I completely agree again with Dr. Banerjee. Clearly, we are not doing a good job debating each other because we are agreeing with all that we are saying. So we are just standing outside one of the oral abstract sessions in which MRD was a focal point of conversation. And I just wanted to highlight one of the oral abstracts that my colleague Dr. Corday from Memorial Sloan Kettering presented in using MRD to de-escalate therapy, maintenance therapy, exactly as Dr. Banerjee said. So basically, it was an investigator-initiated trial done at Sloan Kettering, and the high-level results of it is that patients who achieved at least 2 years of MRD negativity were eligible to be de-escalated. 2 years of MRD negativity were eligible to be de-escalated. And what we really found was that after stopping lenalidomide maintenance therapy, at the 12-month mark, almost 89% patients still continue to have MRD negativity. And at the 2-year mark, it had dropped down to 78%, but that's significantly high. That's 2 years of treatment-free interval of MRD negativity. Did patients convert during this time? Yes, quite a few patients did. However, very few patients were reinitiated on treatment because they did not meet criteria for what we call true progression. And these patients did well. It was found that they do behave, this MRD positivity do behave in a sort of MGUS-like phenotype, exactly as Dr. Banerjee said. And there's a new term that is emerging that we call it as sustained non-progressors. So you have MRD positivity, but no other evidence of disease, and that is now going to be termed by a lot of experts in the field as a sustained non-progressor. And this is a state we can potentially watch and not really place patients back on treatment, and patients can just continue to be closely monitored for evolution of disease. So as you can see, MRD continues to be a focal point of conversation. We are going to see how the field evolves and how we can really use MRD both as a tool in clinic and both as a tool in clinical trials to try to get drugs to patients faster.